Good morning, Dr. Johnson, Dr. Zhao, and Patrick. It's a pleasure to be here and an honor to be a part of this kickoff of this important forum. I was struck in reading the materials that had been put together before coming that this is an area which actually our programs have not paid enough attention to, and I hope actually by the attention you're giving to it that we can trigger more effort to give attention to the informal sector on the one hand and public-private partnerships, which we've actually been involved in quite actively for many years, and put the two together. During my brief time here with you, I hope to give you some frameworks that may be helpful in thinking about pegging things in the conversation. I hope to identify some areas where there either an existing public-private partnership or an opportunity to have a partnership, or maybe some work could be done that would eventually lead to a partnership that would be constructive and helpful both for the health system of a particular country and especially with respect to this morning's discussion, those in the informal workforce, an area that is neglected and in many ways in the statistical systems of the countries where we work is sort of a black box. A lot of the statistical systems don't do very well collecting information about what's going on in these places. Let me see if I can click this right. There we go. Okay. I will cover three areas with us this morning. I'll give you a quick overview just to be sure we're all on the same page with sort of the naming conventions and some key areas related to health systems and health system strengthening. Second, I'll cover some of the dimensions of universal health coverage, and I congratulate the forum on picking UHC as being a sort of a framing point of reference with respect to this topic. I think it's an excellent way to put our various areas of expertise and experience into a workable frame of reference. The universal health coverage movement is a global, worldwide part of the health systems of virtually every country in the world now. And I will show you some things that I think will help us use that UHC initiative as a way to frame and perhaps activate some things, some nurturing and incubation, as Dr. Zhao suggested. And third, I will walk through some key pieces of health insurance and health financing, drawing on work that's been done by some of you in the room and outside colleagues who have worked on this area for many years, to put the sort of moving parts into perspective so that we're all moving in the same direction with respect to this topic. Okay, let's start with the health systems part first. The World Health Organization has been quite active over the last 10 years in identifying key parts of the health system to give attention to. I will not go into great depth about this. This is more of a sort of reminder slide. The reminders are two. One, don't forget about any of those 6 areas. And remember, as a part of that, that they are about the public sector and the private sector, the voluntary parts of the system, or about promotion, prevention, cure, and activities involved with the health system back-a-ways in the sort of input side of things and actively in the middle of actually the patient-provider interface itself as well. And members of the community and family members are a part of that health system as it's shown there. So that's sort of all one first point. Second point to remember is these were first presented by the WHO as, quote, building blocks. And although that seemed like a reasonable way to put these together, it caused people to think of them as being sort of linear stacks. And in fact, I was responsible for approving the cover of our first report to Congress on health systems with 3 children playing with a stack of blocks, children's toy blocks, all stacked together. And they said, Bob, why did you do that? This makes them look linear, which is actually true and misleading. That murky stuff in that Venn diagram is intended to keep us focused on the fact that financing affects medicines, medicines affects governance, governance and regulatory activities, Dr. Zhao was mentioning a second ago, affects things related to the workforce and service delivery. These things are very interconnected, and it would be misleading or not helpful to our enterprise today to disconnect them in such a way that we don't remember the way that they interact with each other. This is a little busier diagram. You can sort of neglect the bottom part. Those are the building blocks, functions, or components, depending on which school of thought you come at this from. We've added a couple 3 to the 6 just to remind us that in case people are doubtful, that the private sector is in the stuff at the bottom amongst the key components. Promotion and prevention is an important part of the health system of every country and every aspect of health programming. And the technologies related to information systems, e-health and m-health, over on the left-hand side also are a key part of the process. Up in the middle, I wanted to bring to your attention then the outcomes, the objectives the universal health coverage movement is pursuing, so that we can think of a sort of guiding star by which to direct our work. So over on the right-hand side, those 3 boxes, financial protection, the essential package of services, and coverage of the population are the 3 objectives or areas within which in the World Health Organization's documents and others, we've agreed to pursue improvements and reforms to get the system right, so that we push all 3 of them, and I'll cover all 3 of them again in a second with another diagram, but those are the 3 that are especially attached to universal health coverage itself. And fourth, the World Health Organization in the World Health Report for the year 2000 identified one more area that health systems strengthening efforts should give attention to, and that is responsiveness to the people's expectations. This goes to issues related to stigma and to the basically customer friendliness aspects of health systems, or not. And a key area needs to be given attention in addition to making sure that reforms make people healthier, and that is actually the final outcome and most important one. Up at the top, I just wanted to make sure we were all aware that the US government and the agencies involved with the health programming in developing countries has 2 big objectives at the moment, 2 initiatives that are giving light and direction to the work that we're involved in. On the left, ending preventable child and maternal deaths is a concerted effort on the part of the US government, UNICEF, WHO, and the World Bank and others, and countries around the world as a part of an effort to basically work on maternal and child health as an initiative that grows out of the old child survival and maternal health initiatives of the past. And second, an AIDS-free generation. The current framing of the work related to the PEPFAR initiative under the administration that gives a light to the goals and the moving parts that are involved with the current AIDS program. So those are the impacts. We work our way up the chart. This conversation this morning will be looking at a lot of the stuff at the bottom, but keep in mind that we're trying to reach those goals in the middle on behalf of the 2 impacts at the top as a part of our programming. The organizers asked me to point out as I go along some references and tools that we have that would be perhaps useful as devices by which to better understand where we're going and what we what we already have figured out how to do that would be useful to moving our programs forward and our discussions. So this is just a few of the sort of data systems and tools that the US government and USAID's programming has given light to up to now, and which we provide support. The left-hand side is an example of a demographic and health survey report from the one for Bangladesh. The DHS is a household survey that's conducted every 3 to 5 years in practically all developing countries where we provide assistance. Now going across, we have a health systems assessment approach that the US AID programs has put together. The World Bank has another one, and a number of other organizations have them, but it's possible to assess the health system, so to speak, and to help set priorities on the areas that need to be given attention as a part of programming. On the right is the IRIS system, which is now being rolled out in a number of countries with USAID support for human resources development, and to collect data that would actively put in perspective that important health worker resource that's that's often a black box, often misleadingly characterized in the data systems that have been available as showing where workers are that actually don't any longer exist, and so on. So that's a problem. Down along the bottom, the National Health Accounts tool, which was developed with the assistance of many people, several people in the room, is the way we keep track of the money. It's the following of the expenditure patterns from sources to uses, and an important part of the conversation this morning in guiding policies that countries will follow. And on the right-hand side, the service availability and readiness assessment, or the service provision assessment, as the DHS calls it, is a joint effort by the World Health Organization and USAID to put a picture of the facility and its availability and readiness into a data system for use by policymakers. And one last snapshot. The President gave this boost to our work on health systems in a speech in May 2009, which we appreciate, and basically that there is a binding constraint to further progress, and that is the weak health systems within which the countries are operating. We take now the second of my three topics. The universal health coverage, this I understand from the organizers, will show up in slide decks all through your 2 days, so I will not dwell on it at great length. Just to point out first that the three dimensions are critically important as a part of a conversation, any conversation about universal health coverage. The two horizontal ones along the front are the population covered, the ones down the side, the services available, have in some of the more recent conversations been kind of collapsed into access related to services of defined quality. And so depending on which conversation you're having now, filling the box up on the sort of horizontal plane either can be split the way it's shown in the cube here from the World Health Report for the year 2010, or can be worked out to be covering a combined objective that's looking at access. The vertical one goes to that point that was on that earlier slide about universal health coverage that says basically we want to protect people from being bankrupted by having an interaction with the health system that takes their assets away from them. Or, looked at another way, we want to make sure that also that they're not denied opportunity to get coverage or services by virtue of the gatekeeper of a fee system that's beyond the means of a family member who needs care. So there's a whole, an important body of literature and experience now on how to deal with financial protection. And that's what that top one is. It's basically putting in place some financing mechanism that protects people from having to pay at the point of service if they don't have the means to cover the cost of them. So that's all I'll say about that. You'll be seeing that cube, I think, over and over again through the day. And one last diagram then. This is a conversation especially about informal employment. In the materials that were provided to us for the discussions today and tomorrow, the International Labor Organization's declarations and discussions have made definitions now available to us over the last 15, 20 years that pull together what's going on with respect to the labor pool of a given country and define key categories. And in a report that was produced at the World Bank by Ricardo Bertrand just last month on health services, universal health coverage, and the informal sector, a report that I encourage you to take a look at, he helpfully diagrammed that same set of definitions. And I just thought it was helpful to my mind after reading the words to see it in the sort of the boxes. So the light colored boxes are the informal employment, and the dark colored boxes are the formal employment. On the left-hand side are those workers and work situations that are in enterprises, and on the right-hand side is those in households. Altogether, we're talking about non-agricultural employment. I just thought it was helpful to sort of get a picture of where these people are in each of the different work settings that they may find themselves as a part of our conversation today. Okay. Now, the key lesson after 20-some years in my own case, and others of you working in this even longer than I have, is that the current situation in financing of the health sector of countries spread across the formal sector and the informal sector and people in urban areas and rural areas is that they've sort of been divided up into small categories that the politics and the economic situation of a country presented as an opportunity to move forward. And it's in little boxes. It's in categories that were politically acceptable at the time they were created. And in many cases, the financing arrangements stay in place for years and years and years. And so this somewhat weird-looking diagram is intended to remind us that if you're going to reform, improve, or expand the coverage of a country, you start from a base, as you'll see in the suggestions that I make in the slides that come after this, of looking at what's there already, and it may be in all different shapes. So this is just a stylized picture of what's going on in an illustrative situation, where on the left-hand side, employers, civil servants, private commercial insurance may be all present for the formal sector, and on the right-hand side, some combination of arrangements with respect to fees or fee exemptions, and therefore a subsidy from government often, and community-based health insurance, that's the CBHI at the bottom, and vouchers and various other payment arrangements may be in place also to help provide the financing for the system as it stands now. So this is a sort of a picture of what you get when you get started with a conversation about how we're going to fix the financing to cover more people, especially to go after the complicated issues involved. We're looking at the informal sector in the various places in which the informal workforce finds itself. So I think this is a rich area to take up for purposes of looking for public-private partnerships, but it's going to take some work. And I think it's important for us to keep in mind that there's some details here, although I will not go deep into every aspect of this, and you'll see me moving along some wordy slides, which I'm leaving for your reference in the future to look back at. But I think you'll see that with some work, building on experiences already and perhaps looking for opportunities to move forward with arrangements that piece together existing public-private partnerships to work on financing adjustments and service delivery arrangements that now could make available service arrangements for the informal sector that are not present there, that we can make some serious progress. But it's going to be a complicated and tricky dance, I think, and so I will walk with you through this process to see where we can get the most early opportunities, some early wins perhaps, and then some more complicated things. I would first like to, before I switch to the next slide, recognize the work of the Rockefeller Foundation in this topic, and as I understand it, they're the major supporter of this forum, and also the work that they got started with the Joint Learning, the Joint Learning Initiative. The Joint Learning Initiative on universal health coverage has been an opportunity and another forum basically for countries to come together with the support of Results for Development, the Institute here in Washington, D.C., and a number of other organizations around the world to give attention to dialoguing with countries about the problems of moving to progress on universal health coverage, getting at the details that I will be covering in these next slides. And their leadership, it seems to me, has helped us move forward and pioneered a number of areas that otherwise would not have been given attention. Okay, here we go. I'm going to cover the 8 areas that are in these boxes, the roof on the top there, the 6 boxes down through the middle, and the all-important foundational area of monitoring and evaluation at the bottom, rather quickly, not to upset you, but rather to just give you a taste of these key areas without delving into great detail. At this point, we can easily, in the question and answer, come back to any areas that you'd like to cover more or where you feel that I may have misled or misstated the case. But I think these are all important areas to give attention to. A second document I encourage you to take a look at that this is based on is the Handbook on Health Insurance that was published by our Health System 2020 project, or USAID project, in 2011. And in a joint effort with the World Bank and the World Health Organization, was used as a training device, a training course and manual to provide training for a number of countries in French and English-speaking Africa as a part of the ongoing effort we have to giving attention to health systems. So that manual is available on the World Bank website. There we go. What you'll see in just a second is that these areas that are in the bar across the middle and the top and the bottom all interact with each other. And sort of like that first slide that I gave you, it's important to keep in mind that the process of actually developing a reform in a country and developing an opportunity to intervene with a public-private partnership will find itself in the middle of a conversation that's constantly recycling these key topics and looking back through for opportunities to redo and take knowledge from one piece and improve the solutions that are being considered for the others. So I just remind you that this is not a linear piece of work. This is one which has to cycle and be interactive as a part of the similar kind of Venn diagram as to the one that I showed first. Okay, let's take the roof. The roof there is called Feasibility of Insurance Design and Implementation. And this is the messy part of starting off a conversation in a country or renewing a conversation in a country where the situation is, as in that jigsaw puzzle that I showed you earlier, a given set of financing arrangements are in place. The politics are whatever they are in a given country situation. And there are gaps. There almost always are gaps. The parts of the population are not getting covered either by services or being covered by services which are beyond the means of the families that are involved. And what we will see then is that a very important early step then is to look through and find those gaps, to have conversations about this, the availability, as it says in the middle, availability, quality, and capacity of providers, and to look at the way in which the insurance arrangements, if there are any, there may or may not be any, and fees and other finances are working their way through the system as it currently stands in a given country. Small countries are often in small and poorer countries are often in a position of needing different kinds of help than bigger or richer countries. But these same sets of issues are an important part of the conversation to develop a sense of the feasibility for making a redesign and change in the insurance system of a given country. Ultimately, policymakers have got to be brought together from legislators, it says at the bottom, legislatures, the executive branch, private sector, civil society, to have a conversation about what's possible, how can we make a change given the situation in our society. Okay, we have some tools. An important one developed several years ago by Professor Reich at the Harvard School of Public Health on political mapping has been a time-tested arrangement for helping look at who the stakeholders are in a given forum for health reforms. And I encourage you to take a look at that if you haven't seen it before. As I mentioned earlier, getting the data out on the table about where are the resources, health accounts, there's the expenditures and service access are important and valuable as a way to get a picture of what the situation is now. And tools to look at the communities and look at the cohesion of this community and the opportunities for changing the arrangement for financing and services are all possibilities, are areas that need to be given to see what are the possibilities. We have a fair amount of experience collectively in looking at community-based health insurance as a sort of starter area for working on an insurance in an underserved populations. We know a lot about what will and won't work about them, so we have quite a few tools about them. Recent literature is suggesting that the opportunities may not be as rosy as they had seemed maybe 5 and 10 years ago, but there are opportunities there nonetheless. Some barriers, and you'll see in each of these slides that I put together, I've suggested a few barriers that I think need to be given attention with respect to our focus here on in the informal workforce. These are just a starter for our conversation, but they're are certainly by no means intended to be exhaustive of this area. Major stakeholders may not be aligned with the informal workforce or even aware of them. The informal workforce may not accurately be captured in the statistical systems and studies of a given country. Therefore, you're not actually going to be as well informed. It may be that the statistics leave them out. And it may well be that the beliefs and behaviors of a particular part of the population may not be clear as a part of the reform participants and stakeholders, and that making sure that there's a clear understanding will be an important thing to do. This is just I've got a quick example slide in each of these, and I won't dwell on it, but this is an example of the mapping that can be done in the political mapping process. This is the situation in Ghana back 10 years ago at a point of transition for that country and its health insurance arrangement, from an arrangement of community-based insurance to considering how to move forward with a reform that would be more uniformly covered covering the whole population. Okay, let's take up the 6 boxes, and I'll move these along a little quicker. So the first of them will be financing. Financing, where we look specifically at the insurance arrangement itself. And these are just some of the basic principles, but not by any means all of them with respect to insurance. The insurance basically has to hold water. It's a risk arrangement intended to put money in such a way that it will not be depleted faster than is needed. And the arrangement for doing that works best if the pools for financing are as large as possible and have a variety of protections to make sure that they're not depleted inappropriately as a part of the process. The money can come from premiums or taxes, but altogether, in order to protect the interests of the population and the country's citizens as a whole, it has to be done competently by experts who in some cases are not necessarily going to be available in a given country. So this is an important and in some cases quite arcane area that involves experts of a variety of kinds. We have a lot of tools. The tools help move the process along. They depend on good data, and if you don't have good data, then they will be misleading. And so we want to be careful that we're not misleading ourselves as we move forward in that process. The tools there look at both the finance and economic issues that are involved with the system, financing that's being considered, and look at the cultural factors and political ones. Political will, nonetheless, at each stage in all these boxes is critically important, as I'm sure you all appreciate. Down at the bottom, a couple barriers that came to mind. One of them, that the informal workforce may not be organized or officially recognized to participate in a scheme, and therefore it may be hard to find ways in which to bring members of the informal workforce into an organized insurance arrangement. And second of all, the data that could be used for actuarial and utilization research, studies that would inform the financing decisions may not be available properly in accurate form and timely form to guide the process. So this is a slide that just says this takes a long time. That last step is basically mapping that jigsaw that you saw on that earlier slide. This is Thailand, one of the stars up to now in working on this area. This is covering from 1974 at the top down to 2002. They're still at it. They've done an excellent job in overcoming problems and getting at different parts of the population. The boxes across the top are about the private sector, government employees, and then everybody else. And it's a tough process to make progress, and they've in fact done it, and to be congratulated in the progress that they have made. They still have some holes in the system, but not very many. And so we often go there to see what they did and how they did it, because a lot of the lessons that we can take to other places come from the Thai experience. But that's 30 years of experience right there, a slow process of moving forward to get the people of their country covered with universally. Let's talk about the next box, population coverage. Basically, what we're trying to do is get at inequities and group populations by characteristics so that we can make the most sense out of the needs of each population group. There's an economic term called adverse selection, which is important here. Basically, potential consumers know their own risk levels, but the insurers do not. And so this is people signing up when they're sick. If you use the V word as a part of your insurance arrangement, if they can voluntarily sign up and join. If all the sick people join and all the non-sick people don't join, as you had in the conversations here in the US about the recent reforms, that wouldn't be a good situation and would doom the financing system to a, quote, death spiral, as it says at the bottom, I think quite appropriately. So looking at population coverage is a tricky thing and an important one that needs expertise well informed by the situation in the country. And so outsiders paying attention to this can guide some of the steps of it, but this takes a lot of keen insights about the characteristics of the population and the different political, tribal, cultural patterns of the country to make sense out of it. And I've suggested some barriers, location of people, the age and gender and health status of the people, and especially the And these days, the special burden of HIV for informal workers probably is an especially complicated issue to take up. This is just a quick example of a diagram that basically you try to pull up stylistically, mapping who's in what to make sense out of the different health insurance arrangements that are available in a country. The benefits package is important. What you're going to cover and not cover is critically important to looking at these programs. How to determine which services should be in the benefits package is an important step along the way. It may have to be revisited several times. And who should pay for which parts of the services, which are not necessarily needed for insurance reasons. That is, they're not ones which could threaten a family with respect to catastrophic costs, but which may be needing attention as priority services, such as family planning and immunizations, to be covered under an insurance arrangement as a way to get the delivery systems all aligned together. There are lots of tools to look at these benefit packages. They're complicated to use in some cases, and costs as well as benefits need to be projected and modeled as a part of that process. It's important, as it says in the barriers down there, to design the benefits to increase utilization and find ways in which people who've been cut out of access or in the gaps, as I said in that earlier slide, can get attention as a part of the financing reform, or else, like, why bother to do it? We're trying to achieve widespread benefit of the interventions of the priority areas, such as those that I mentioned under our EPCMD and AFG initiatives of the U.S. government. And the question is, where can they be fit into an insurance arrangement that was intended also to cover risks of catastrophic costs? So here's, I will not go through this all in detail, but this is, I thought, a helpful, from the health insurance manual, a helpful reminder of the personal priorities and the social priorities and some of the economic and financial and actuarial issues that are involved with choosing the benefits package. It's, I think, a neat reference for you. Provider engagement is the service delivery arrangement, and both the services themselves and the financing arrangement that's involved. Create payment systems with incentives to the providers to improve quality and equity is certainly a good principle to follow. And arrange the insurance policy in such a way that providers and payment methods are lined up in a way that's acceptable all the way around. And the policy goals in that list of the fine print are critically important ones. So we do have quite a few tools, and a couple of them actually came up with Dr. Zhao's presentation a second ago. That fourth one, pointing to the use of franchise models for service delivery, I think has great merit, does offer the opportunity, and has already in a number of places in Asia and in Africa, for public and private partnerships to stimulate high quality service delivery, keeping costs down, making sure that they're available in areas beyond the sort of urban centers of a country where services may not be readily available yet. And so that it seems to me that there are a lot of good possibilities for the use of franchise tools. This, it seems to me, is a good best practice or best practice in this area. We've covered a lot in our last 10 years of work on this area with incentive-based arrangements, or PBF, performance-based financing, that also fits in at this point in this arrangement. That's where the incentives come in. And we know quite a bit now about what works and what doesn't work with respect to those tools as well. Providers and the barriers. Providers may not be located in such a way to be accessible to the informal workforce. And the T word comes in critically important here, but I should have probably put it on every slide. As you'll see in the literature and those studies that I mentioned, in Ricardo Bertrand's study and in the work in the handbook, trust is critically important. You can have a conversation about this stuff, but you're talking about personal matters of great importance to a family, to political groups and so on in a country. And where trust breaks down, conversations about these kinds of reforms becomes almost impossible. So being trustworthy is a critically important part of this. This is a checklist on provider payment arrangements. This is not exhaustive, but is illustrative of some of the arrangements. I will not go into it in detail, but you have experts on your forum that can help apply these where needed. Two more. Organizational structures, critically important to getting the pieces of the puzzle in line to make an efficient arrangement that will pull together the insurance and financing arrangement in a way that is accountable, as it says in that second slide, accountable, transparent, answerable, and controlled. It's critically important that transparency be given high attention as you organize a financing system. The ones that have collapsed or have been suspected and not trusted by families in different parts of the world that we've worked on have often had great difficulties with corruption, and you put a lot of money together in one place and you have to be careful, because that's sort of true everywhere. Here's some core functions. I think that's a useful checklist from the handbook. And core governance, down my two barriers there, core governance and management arrangements and staffing may not be aware of the needs of the informal sector. I think it may well be that they're just neglected out of ignorance. And there aren't very many options for involving the informal workforce often in the policies and management arrangement. And we don't know a lot about how to make that work out better. Here's RSBY, the India system, and its organizational arrangement as of a couple, 3 years ago. And the third-party administrator in the middle is a sort of switching point for the way this worked out. This is rolled out state by state across India on a sort of voluntary basis as a part of a national process. It's intended to work on hospital care. And the key innovation in this one that I think is critically important for us to realize, these innovations will show up almost anywhere in this process, was the one in the middle of the blue circle. The smart card turned out to be the innovation, to my mind, looking at the situation, that sort of came by surprise to me as being one which was critically important to the success of this arrangement. And although RSBY has had, given how huge India is, a massive challenge to do what it's done, to scale up what it has, a critically important aspect of it was to be sure that beneficiaries could be identified in a way that you could rely on, and its accuracy and the honesty of the people who put the system together. And the smart card with the chip in it and the arrangement of controls for how they're issued and used, and the telecommunications arrangement that's worked out to interact with the card itself has proved to be a best practice that could be used in other places. It may not be the smart card to be used across the world, and public-private partnerships looking at this key area for innovation should keep in mind that identification devices are critically important to these arrangements. Last of my 6 boxes, operations. This is all of the back office parts. And a key part of this, I wrote this in a bit of fancy here, a plan to apply e-health and m-health technologies to jump over the legacy technology. What we're seeing is that we're finding that handheld devices, internet connectivity, arrangements with health information systems as they are today permit us to use technologies and approaches which would have required huge investments in infrastructure in the past, and we can just jump over those in these countries in some cases. And they should be applied to these functions. You'll see there's a lot of moving parts there. Those are the back office, critically important pieces. And what we're finding is that the Farm Access and Health Insurance Foundation, the Dutch organization working in Africa as a public-private partnership, is finding itself able to provide trusted services in a lot of these back office arrangements that currently are not, would otherwise not be done as well. And under contract are finding opportunities to move the expansion of services and the expansion of a financing coverage rapidly by virtue of the role that they're playing. So that's another PPP that it seems to me that is showing itself to be especially helpful, and their experience is one I think that's worth studying. Down at the bottom, the lack of a secure means for collections is an important one, and a lack of a robust, accountable smart card, which we at least have the example from India as being a way to move forward with that, are important as well. I have a slide here from M-Pesa in Kenya, which you may be familiar with. This is the cell phone device that has been put together as basically a means of transmission of funds across Kenya, and has then been merged with the help of Farm Access and others, an arrangement for doing health insurance payments and other types of payments within rural and urban areas of the country. These are the results of studies of who's using it and how much money is moving in and out of people's accounts, showing actually a great deal of activity and a great deal of trust in the way the system is working, and in fact, a great deal of efficiency and accountability. So it does represent an opportunity to build on a public-private partnership that could be adopted and applied in a number of other countries, I think, as well. It gives us hope that some problems that seem almost impossible to solve may actually get solved. M&E. I will not go into a great deal about M&E, all to say that most of the insurance arrangements that I am familiar with did not have much in the way of M&E put into them, and they should have, and especially given how complicated each of them turns out to be, giving upfront attention to monitoring and evaluating, monitoring the rollout and evaluating, looking for the impacts is critically important. The World Health Organization, the World Bank has agreed on a set of protocols related to universal health coverage. That's that bottom bullet. And I put in the reference list at the end of the slide deck, the link to the document itself. There's a protocol then for how countries can measure their progress in universal health coverage, and they hooks together with everything that are in these earlier slides as well. So I'm encouraging countries to do that. There are tools for M&E that look at enrollments, reimbursements, the financial performance, and the utilization and burden of the financial arrangement. But it probably is the case that in almost every country that the M&E arrangements, as such as they are not giving attention to the informal workplace or have an adaptation to be able to do that. So with that slide, let me just see where we're going here. Okay, I've got one more. Here we go. So with this slide, I've finished my circle and the roof, the pieces in the middle and the bottom. And this is an illustrative M&E arrangement intended along the side to give basically the key parts of the project structure at the top, and then the indicators, and then the M&E arrangement in the middle, and the data sources at the bottom. It's from the Health Insurance Manual, and I encourage you to take a look at it as an illustration of where you could go to arrange an M&E and a proper M&E arrangement for this program, this kind of a program. In finishing up then, and this, I appreciate you wading through all these pieces with me. I've tried to present you with first a dramatization of the importance of universal health coverage and the opportunities to provide reforms and financing that would help countries move forward to cover the population you're here to talk about, the informal workforce. I think public and private partnerships already have shown themselves to be excellent means by which to jumpstart activities and programs to move forward. And I think involving different groups that are currently working with the informal sector is a means by which to move forward with perhaps incubators, as Dr. Zhao suggested, to try out ideas to make this activity move forward. In closing, I wanted to show this slide. This last week, Jupp Lang, the innovative Dutch physician and researcher, passed away on the plane that crashed in the Ukraine. He was the founding vision behind Farm Access, the arrangements for the health insurance fund and the medical credit fund, and the Safe Care program for looking at improving the standards of quality in care. And I guess I can't think of a model of excellent public-private partnerships to think about as a part of the work of this forum than his activities in all those areas over a very long period of time. And we regret his loss. Here are the references that you have available that show a number of actually recent studies on the informal sector and how to deal with financing. I encourage you to take a look at them, and I thank you.
You have a couple of minutes left for questions, so if members of the forum have questions, You can raise your tent card. And Bob, if you're able to stay, we'd like to have you move to the table. Once you've complete your question and answer period, and then perhaps there'll be questions for both you and Murai Chatterjee, who will follow you. So.
Please.
Yeah, this is an interesting morning. Can you hear me? Is this on? Yeah, interesting morning. And the one word I haven't heard all morning has been research. I've heard innovation, I've heard M&E, but it just struck me that in Victor Zhao's presentation, under what academia can do, under finance, and what we've talked about are creative finance mechanisms, there's clearly a role for research around conditional cash transfers and ways to deliver. And Bob, in Bob's presentation here, so much of the innovation that comes into healthcare delivery and the interventions that can be addressed are research interventions. There's a lot, for instance, in the area of mobile phones, we have lots of applications. The extent to which evidence from mobile phone use improves health is still incompletely addressed. So I just think that research has to be built in. And I know everywhere where we talk about money in healthcare systems, research, there's no funding for research or no funding for that portion of this. So I would just ask that that be somehow included in the discussion as we go forward.
Maybe to continue on that theme, Bob. I mean, I think there was quite a contrast between Dr. Zhao's presentation, which I think really ended us with a very positive feeling of innovation in the technology space and partnerships between the private-public sector, which is what this meeting is about, and yours, which was, let's face it, a rather depressing, realistic view of a pace of progress which would take us 3 decades at the best. I think we have to really think more deeply about the 3 little white boxes that you showed in your slide, which was called Strengthening Health Systems, which I suspect were almost added at the end. E-health, private-public partnerships, and health prevention and health promotion. And to my mind, they should be at the top. And you should think about how we could cut through the legacy stuff that you've got up there and go right to the end slide, which you had. The fact that Mbiso actually is transforming the way money moves in Kenya, the way that you showed us what is happening in India, the dimension that Roger had about innovations, not just on technology, but in behavioral economics, which is what conditional cash transfers come out, should be put first, not last. And I say that quite seriously because I think that what you presented would be very nice in a WHO meeting. And having been at WHO for many years, we would look at that and say nice and spend the next 4 decades thinking about how we're going to implement it. This is a meeting that can draw upon the innovation of the private sector in the fastest moving area of technology innovation the world has ever seen, and yet it's put as a footnote. So I would urge that we turn this entire thing on its head and say that you're going to cut out the traditional route, which will take us, as you said, 3 decades or longer, and say, well, how do you actually start off by saying innovations in technology and better insights into behavioral economics in the countries where we want to work are transforming the opportunities for us, and start with that point, and then see how you can address some of the other issues.
Again, well, Bob, thank you. That was thorough. I thought the history was superb. I think you brought us up to current level, especially at the end where you presented us with references that will be germane and essential as we go forward. I think we've begun on a very, very smart and positive note, and I'd like to now introduce Murai Chatterjee, who's the director of SIWA, who's going to talk to us about universal health care coverage and occupational safety and health in India as these relate to the informal workforce. Thank you.